welcome to another Piper Pod. Today we're going to continue the cardiac theme and we're going to look at algorithms. So these algorithms are an introduction. What is strongly encouraged from here is that you take these algorithms and knowledge and you interject them within your training. Okay, so you actually practice these principles and you decide as a team that you're working with how you're going to implement them, what you're going to consider. That's what we hope to get out of today. So we're going to start with everybody's favorite, okay, the advanced life support for adults. Now we do this regularly. It's something that's practiced all the time. So I'm not going to go through the actual algorithm for this one. Instead, what I'm going to do is point out considerations that I've noticed throughout people's training and just give you a little bit of knowledge of things to consider implementing within your practice. So if we start right at the start of the algorithm, you've obviously identified that somebody needs CPR. Early CPR, we all know, is fantastic. Early defibrillation, we all know that's part of the chain of survival too. Getting that defib and attaching it is often lost in translation, okay, mostly due to our training mannequins. So we'll go through it now. If you start CPR and you don't have a defib attached, then you are to continue compressions whilst that defib is being attached. Now, if we look at our mannequins, you'll notice that you'll have 2 points in which you can attach these defib pads. The problem is the one that's down on the left really needs to be far more laterally than our machines sort of have us believe. So on the machines, you'll find that the actual electrode is more mid-clavicular. The place that we need our defib pads to attach is fully laterally. Okay, so within the actual axilla line is where that pad needs to be. So encourage you all to look into this itself. Okay, find where the actual pads need to be and then start practicing sticking pads on those sides and then attaching the monitor to it in order for the machines to work. It may seem trivial, okay, but there's been a lot of people in the heat of the moment that will naturally do what they do in practice. Put one right, and then they'll fail to put the lower pad as laterally as it needs to be. Also research that there's alternate sites that you can utilize. So if the top right can't be used, then you can go laterally. Okay, so one pad on one side and one pad on the other, as long as it passes through the heart. Okay, so look into those sites that you can use and then start practicing them, because some of our patients cannot have defib pads put in. Okay, it can be as simple as having someone that is extremely hairy. Okay, you can take the time shaving the person during CPR, or you can just put the pads lateral sides. Okay, so just start thinking about those things now, start putting them into practice. Next thing we're going to talk about is when to defib, okay, and then how to defib. So it's often said that if you have the defib pads on and someone goes into cardiac arrest, you should shock them straight away. Now, most of the time, that's absolutely true. Okay, early defibrillation, that's what's going to help. Okay, that's what helps reset the heart, basically cuts out all milliamp activity within the heart, and then hopefully allows automaticity to come back in. If you have it attached, you can, but just consider what was the causative agent of the cardiac arrest. Because if you have a heart that is not perfused, and that's the problem, like cases of severe hypovolemia, then you can shock that all day, every day. Okay, and it will not come back. It'll have no chance, basically nothing for it to connect to. It needs to be perfused in order for defibrillation to work. So all you do there is just do a few compressions beforehand, not the full 2 minutes, but a few compressions, and then deliver the defib. Now we'll talk more about completely unperfused hearts with the next algorithm, okay, but just consider that sometimes you may need to do CPR for a little bit first to increase the probability of the defibrillator working. Next thing I'm going to talk about with defibrillation is the use of manual or automatic defib. The reason we like manual over automatic is the time that it takes off the chest. So an automatic, you'll get to the 2-minute mark and it'll say that it's analysing. So the machine itself will need to analyse first with no interruptions, and then it will need to charge itself again with no interruptions, and then it will need to wait for you to do your safety checks to deliver the defibrillation. Now some machines, this can take up to 19 seconds for it to analyse and then subsequently charge. So it's 19 seconds of interruptions. Now, if all the literature out there says minimal interruptions, it's pretty easy to see why using automatic is essentially the way to go if you're a first aider. First aiders use automatic. You guys are clinicians, so you should practice manual defibrillation, always. Now, when you're doing manual defibrillations, there's two options that you can utilize, and this is something to practice with your team. Okay, the first option is you use that coach method. Okay, and that's something that gets pushed out there all the time. That's the one where the compressions will stay, oxygen will move away, and then you'll charge the machine. Once the machine is charged, the compressions will stop. During that period of time that it's stopped, you'll be looking at the rhythm, deciding whether it's shockable or unshockable, and you'll be delivering the shock or dumping the charge. Straight after one of those two things have happened, the person will jump straight back onto CPR. Okay, so that's the first option. The second option is you momentarily pause the compressions to have a look at the rhythm, decide whether it's shockable, non-shockable. It should be done in less than 5 seconds, and then compressions jump straight back on. Based on what you saw, you either charge whilst compressions are happening, or you just continue 2 minutes of CPR. The reason that this second option has come around is because 80% of rhythms during cardiac arrest are non-shockable. So using the coach method, you are charging and needing to dump the charge 80% of the time when you're dealing with CPR for adults. Now, what's happened in studies that have been released by the UK is trained personnel have been not disarming the defib, but actually delivering the shock to the person. Now, these are trained personnel, okay, and this is what they've found. So they've been defibbing the person when it's not needed and defibbing the person when people are touching the person as well, because they'll jump straight back onto CPR. So it just has that risk. If you see a shockable rhythm, CPR jumps back on, then you charge it while CPR continues. When it's charged, then you say, everybody stand clear, check the rhythm again, probability says that it's going to be shockable, and you deliver the shock in less than 5 seconds. And then you jump back on the chest. Either way, it's still better than automatic, but it's something for you guys to practice, for you guys to get down as a drill. Okay, I'm not going to tell you how to do it, but there's your options. You may come up with a different option, you and your team. It doesn't matter, but practice your manual defibrillation. Next thing we're going to talk about is the use of airway adjuncts. When you're using airway adjuncts, doesn't matter what it is, LMA or an ET, it should always have waveform capnography on it. I'm not going to dwell on it, but if you don't have waveform capnography, well, you do have it, you got it with the MRX. If you're not using it, then you're kidding yourself. If you have waveform capnography, always put it on the end of the adjunct. When doing it on an LMA, make sure you have a filter in between the LMA and the capnography. They actually regurgitate, you protect the waveform capnography with the filter. That's all we're going to say. Now, airway adjuncts themselves. It's encouraged across ALS courses and when you're in major facilities to use the Bag-Mal vast to breathe for the person. And that's often done for the first couple of cycles. Two shocks have been delivered, adrenaline's been delivered, and then you'll start considering putting in an advanced airway. Things that we should consider is that we are not experienced practitioners when dealing with BVM. And what the study has shown is that if you are not an advanced practitioner, that you will fail at the BVM. You will not have the skill set, you will not have the tactile training in order to hold, get a good seal and good chin lift by yourself in order to deliver good ventilations. The ARC actually recommends that anybody like us that doesn't do it regularly, we should use 2 people to deliver IPPV via BVM. One holding the mask down and giving chin lift, the other one breathing. That's 2 people out of commission when you're doing your CPR. We only have 5 in the whole resus tent. Okay, it's not a major hospital where you have 40. 5. That's all we have. Okay, so consider that. So for us, upgrading to an LMA quickly and earlier could be a consideration. Okay, because once it's in and it's secured and using the licorice stick at the end with the BVM, then it's a lot easier. You can deliver the breaths, and you know that every breath you put in is actually going to get given to the patient. Okay, so big advantages all round. The second advantage is once you have a supraglottic airway in, you don't have to stop compressions for breaths. So if you're using a BVM, the council recommends 30 compressions, pause, 2 breaths, 30 compressions, pause, 2 breaths every time. As soon as you get a supraglottic airway in, you just continue those compressions at 100 to 120 a minute for 2 minutes straight. The person who's breathing delivers 1 every 5 seconds, every 15 compressions, whatever it is, you'll basically get a range between 8 and 12 breaths per minute, which is what you want. And it will continually happen. The other advantage is when you're defibbing, you don't have to disconnect the oxygen. Once you've got a supraglottic airway in place and a fixed circuit, you can leave the oxygen attached. Yeah, the breather steps away, but you don't have to disconnect it. Okay, so that's massive, massive advantages when dealing with breathing and airway adjuncts. So another thing to consider. We use IOs now. So if you didn't have an IV in place when this person went into cardiac arrest, you could pretty much place your bets that it's going to be very difficult to get IV access now. So you should be encouraged to go straight for IO, and you should implement that in your training. If you come across a scene and already in cardiac arrest, your first point of call should be IO. In the case of non-shockable, you can deliver the adrenaline straight away. In the case of a shockable rhythm, then obviously you've got that access for any drugs that you need to give eventually, after 2 shocks, that sort of thing, but you'll still have that access. Now, later on down the track, always considering upgrading to IV, but it's going to be difficult whilst they're in cardiac arrest. Okay, we don't have ultrasound guide. Even with that, it's going to be difficult, so just keep that in mind. In the event you've got a non-shockable rhythm, you can't get IV access, and they don't have means for you to get IO, either you don't have IO for some crazy reason, or the injuries don't allow you to put IOs in, then adrenaline can be delivered down at ET, not an LMA. Okay, so if you're in a non-shockable rhythm, you'll need to upgrade to an ET, and you need to deliver the adrenaline within the first cycle, okay, and then every 4 minutes afterwards down the ET. And the dose, it's a tough one, it's anywhere between 3 to 10 times the amount of the recommended dose. So 3 to 10 milligrams down the ET. Now, which one you choose, realistically, that's up to the doctor that's there, the doctor that you're talking to, because certain pathophysiologies will mean you've got to give more, considering less. For our demographic, you're pretty much safe to go less, so the 3 milligrams, okay, unless there's some form of respiratory pathophysiology involved. Pneumonia, APO, things like that. That's all we're going to talk about when we're dealing with this particular advanced life support, is just things for you to consider practicing when you're going through your drills. The last thing I'd definitely encourage you guys to practice as a team is the post-resuscitative care. Now, I'm not going to focus on it here because it will take way too long. Okay, maybe another podcast later on. But do your research, work with your team, and really practice that post-resus care. And until next time, take care.